I'd like to thank the ESCRS for the opportunity to share our experience with this exciting technology. Essentially, we all think of AMD lenses as telescopes, and as such, large, complicated, bulky devices. And at the outset, I would like to make it clear this is not a telescope. This is essentially very similar in terms of physical characteristics to a monofocal lens with special optical properties. As you can see there, it's very familiar to us. It's a single piece hydrophobic acrylic with a 6mm optic. As we all know, cone density drops very rapidly as we move away from the fovea. It's about 200,000 cells per square millimeter there, giving us normal vision. But once you're out to about 10 degrees, it's already dropped down to about 10,000 cones per square millimeter. And as a consequence, the visual potential declines also. So at about 3 degrees, it's about 0.6, and out at about 10 degrees, it's about 0.15 or 0.2. What you may not appreciate is that, as well as a reduction in cone density, our natural crystalline lens and any standard monofocal artificial lens, also, if you are looking at the image eccentric to the fovea, is considerably blurred compared to the fovea. Okay, so for example there, at 10 degrees, that is the image that a patient with AMD would be using if they have developed what we call a preferred retinal locus, or a point outside the macula as their preferred center. Now, a couple of concepts we all already accept are the use of prisms in AMD patients. And as we know, these divert the image from the fovea to this PRL that AMD patient may have developed. Also, we appreciate that magnification can help these patients. And there are intraocular devices which have tried to utilize this phenomenon. The optics of this lens, the Eyemax mono, were developed by Professor Pablo Artal at the University of Murcia. And I don't think I need to say anything more about him. He's preeminent in his field. Just to give an example of what 5 or 10 degrees on the macula looks like, this image essentially shows, with a standard monofocal, the very high contrast and good quality image in the center, but moving out from the center at 5-10 degrees, the image drops significantly. The image quality drops significantly. A prism, as we have already mentioned, deviates that image from the fovea to the area that the patient is using in AMD, that we call the PRL. What the Eyemax mono lens does, instead of deviating the image, it optically enhances the image in that eccentric macula. And it doesn't do it in just one specific area that the patient may be using, but it does it 360 degrees, extending out from the center of the fovea. Now, although the lens, if you aim for emmetropia, only has this effect of enhanced image in the peripheral retina, but it's also optimized so that if you leave the patients modestly hypermetropic, you can introduce a degree of magnification. And we've calculated that between +2 and +3 of hypermetropia, they obtain about 10% magnification for distance vision and 20% magnification for reading vision. So just to summarize here on this slide, at the fovea, a standard monofocal lens, which we are showing here in the pictures above, that's the image achieved. But with the Eyemax lens, it would be the same size or magnified and as good as a standard spherical lens. At degrees of eccentricity, and we've got 5 and 10 just examples here, if a patient had a PRL at 5 degrees, the image at the top is what they would be using. And with the Eyemax lens, it's the image in the lower picture. And as you can see, it's a much higher contrast, better quality image. And that is the underlying principle, how the Eyemax mono lens can potentially improve vision in these patients and also help optimize it in the longer term. So the Eyemax lens is not a prism, it's not a telescope. It's a new class of lens, and we've called it an extended macular lens. It optically enhances the image quality in the peripheral macula Okay? And from the patient's point of view, that's the same as though you had deviated the image there with the prism. In addition to that, we know the AMD is going to progress, and even as AMD progresses and the patient develops subsequent PRLs, the image quality is already enhanced in those areas, so the vision will always be optimized. It's preloaded, goes through a 2.5 millimeter incision. It's in over 2,000 eyes in 13 countries, and but there are over 50 surgeons who are using it quite regularly already. We all know that cataract surgery in these patients with AMD can significantly improve vision. And I think I want to start, before I just present our data, just to show a systematic review and meta-analysis which was published in ACTA back in 2015, which showed that cataract surgery in AMD patients can on average improve vision by a mean of about 6 to 7.5 letters of ETDRS. In our study in the UK, we looked at 300 patients consecutively over the previous 2 years, carried out by 4 different surgeons. We have an average follow-up of 6 months, and we looked at the safety profile and the visual outcomes. We only had data for 244 in terms a complete data set for some of the safety parameters, but as you can see here, specular microscopy, there is a very modest reduction. In terms of the targeted postoperative refraction, we are very close to our target with what was achieved, and intraocular pressure postoperatively was modestly reduced, as you would expect after a standard monofocal implant. Important to mention is not a single patient out of these lost vision at 3 months follow-up, and there were no intraoperative or postoperative complications of note. In terms of the visual acuity data, this is for 300 patients. You can see at an average follow-up of 6 months, there was a mean gain in distance of 17 letters of ETDRS and a mean gain for near of 21 letters ETDRS, or you can see the logMAR figures there also. Just finally, I'd just like to point out that a lot of this data now has just been published recently in an article in the European Journal of Ophthalmology, if you'd like further details. Thank you so much for your time.
Due a discussion period immediately after your paper, you say that the lens has been used in extensive areas and different countries. And is the lens actually available commercially?
It is. It's been available commercially for 2 years, but certainly to start with, it was restricted to certain centers, particularly the University of Heidelberg, University of Murcia in Spain, and a few others who are still carrying out studies, including a randomized control trial at the University of Heidelberg. But from this Congress onwards, it is more widely commercially available. And essentially, I think any surgeon who would like to use it, it is available.
Is there any area of macular damage that you think is too large so that the lens won't work?
No, that's a very good question. And these are answers to these questions is what we really need to elicit going forward, because we would love to be able to inform our patients and the surgeons better to identify the subpopulations who have the most improvement. From my experience and what we've seen so far, the larger the lesion, and we suggest more than about 5 or 10 disc areas in size, the patients tend to do not quite so well. Our recommendation from my experience is patients between about 0.5 to 0.1, that intermediate category, tend to do quite well. It can be used in patients with better visual potential, even worse, because it will still behave as a standard monofocal lens, but with very large lesions, we're not seeing the same kinds of improvement as you'd expect.
You said that there was a mean improvement and that nobody lost vision, but were there a significant proportion of patients that didn't actually see any improvement at all, which was balanced against those that had rather a better improvement?
No, you're absolutely right. In about 4% of people, we didn't see any improvement at all. Okay.
There's a question here.
Yeah, very nice study. A quick question. It was unclear what percentage of those patients had cataracts to begin with and whether you ran a control group that got a standard IOL as well.
Again, that's a very good question. It's not very easy to study AMD because there's such variation between patients, between eyes, and how do you define it? Is it just anatomically? And we don't really have the diagnostic tests these days to really define it functionally. So from that point of view, it's not easy to design a study where you are comparing it head-to-head with a standard monofocal lens, which is why we did a systematic review of what was already available in the literature in terms of improvements in vision in cataract patients who have AMD. To that aim, Professor Hengerer in Germany is trying to address that, and he has got a randomized control trial where it does compare this lens against the standard monofocal and with and without magnification. So, and also using some other parameters such as fundus autofluorescence to be able to define the subpopulations better so that we can inform our surgeons and patients who are the better people to be implanted. In terms of patient expectations, we tell absolutely all of our patients this is not a cure, fundamentally. And not only that, the AMD will progress. Okay, but in terms of the safety profile of this lens, if patients are coming for routine cataract surgery and you had the ability to provide them with something with better visual outcomes, and remember I just said before, from our study, only 4% of patients stayed exactly the same, and we tell them that, okay? And also we tell them if they've got a very large area of geographic atrophy, we really cannot predict what the outcome may be. In fact, it could be very, very modest or not at all. Okay? But compared to alternative technologies where the risk associated with the surgery itself being extracapsular, large incision, all the other parameters that go with all, we feel on balance this procedure is much safer and offers better visual outcomes. But
Thank you very much.
Right.
Thank you.